Okay, well, good afternoon. My name is Kelly Piper with the California Healthcare Foundation, and we're really excited to present our webinar, Coming Home, Transforming the Community Healthcare System to Effectively Serve Individuals Returning from Incarceration. As many of you know, California Healthcare Foundation is deeply committed to improving care for people with complex needs, and there's really no one who is more complex because of untreated behavioral health conditions, whether that's addiction or a mental health disorder, and impacted heavily by untreated, unmet social needs and real challenges emerging from the correctional environment into the community. And so we've been working with the Transitions Care Clinic Network for the last couple of years to plan for this moment where we're going to be expanding California's Transitions Clinic Network across the state. So we're opening up an opportunity for up to 25 clinics to implement this model, which is absolutely powerful. It has been proven to improve outcomes and improve the quality of life for those people served. So I'm going to introduce Shira Shavit, and Dr. Shavit is the Executive Director of the Transitions Clinic Network, and she's been working in correctional healthcare for over 10 years, and she launched this Transitions Clinic program along with some colleagues and has been leading that program ever since. Ann Finkelstein is a family doctor with the La Clínica de la Raza, and she's going to be talking about the on-the-ground experience of implementing a Transitions Clinic program in her health center. So I'm going to go through just a little bit of housekeeping and then turn the presentation over to Dr. Shavit. All lines are muted at this point since we expect to have a pretty broad audience. If you want to ask a question at any point, you can submit that question through the Q&A platform at the bottom. Don't use the chat function. The Q&A will work better for this purpose. We are recording this session, and the recording and slides will be available on the CHCF website and the Transitions Clinic Network website, so you can get that at any time. And you'll receive a link with that as soon as the slides and the recording are available. And for those of us on our mailing list, you probably received a blog notice that the Transitions Clinic Network did just publish a blog sharing the experiences from the point of view of community health worker and those involved in the program. So it's a great way to learn more about the program after this webinar. I'm going to turn it over to Dr. Shavit.
Thank you so much, Kelly. I just want to say thank you to the California Healthcare Foundation and to LA Care for really supporting our work and this initiative. We're just really excited about the opportunity to work with more clinics across California. The Transitions Clinic Network is a nonprofit organization that supports primary care clinics in improving healthcare services for people impacted by the criminal justice system. And to date, we have 29 programs in 12 states in Puerto Rico, with 8 programs across California. So we're just really excited about this opportunity to expand our work. And I also just want to thank you for the opportunity today to talk a little bit more about our project. It did start here at Southeast Health Center, which is in San Francisco's Bayview Hunters Point neighborhood. It's an African-American community that is significantly impacted by the criminal justice system. In front, you can see 2 of our community health workers that both have a history of incarceration who are part of our healthcare team. I myself am a family doctor and provide primary care services at Southeast Health Center. So what I'm going to do today, during this webinar is I think it's really important just to spend a little bit of time talking about why it's so important to think about patients impacted by the criminal justice system a little bit differently than other patients we serve. So I want to make sure we're kind of all on the same page. So I'll talk a few minutes about why it may be different caring for these individuals. And then I would love to share the story of how we developed the Transitions Clinic model. As I mentioned, I'm a primary care provider, and this really grew organically out of our experiences working in a community that was significantly impacted by the criminal justice system. So I'll share kind of how the model was created, what the model looks like, and then how we sort of developed a network of clinics doing this work around the country and what this new opportunity looks like. And then lastly, we're really excited to have Ann Finkelstein join us to talk about the work that she's done in Vallejo implementing the Transitions Clinic program. So, thinking about the system of incarceration, as many of you know, we disproportionately impact more people in the United States than almost any other country in the world, compared to kind of our Western counterparts. We're by far and away incarcerating more people per capita. And as a result, over the last 30 years, we have implemented many policies that have led to this, which we call mass incarceration. We've had a tremendous increase in the number of people incarcerated in both our prisons and jails. As a result, 1 in 37 people in this country are impacted by the criminal justice system, either being incarcerated in prisons or jails or on community supervision like probation and parole. So that's 1 in 37. But as we have had more punitive policies over the last 30 years, we see that people who are going to prison and jail are spending longer periods of time incarcerated. As a result, they're aging, they're developing more chronic conditions. And what we know is that people who are impacted by the criminal justice system have higher rates of chronic medical conditions, substance use disorders, and mental health diagnoses. And while when people are incarcerated, they may have access to healthcare services under the 8th Amendment, they have a right to have healthcare provided to them while they're incarcerated. The quality of that care is variable. And as many of you may know, in California, we're under federal receivership because we had 1 inmate dying every week from preventable causes. So negligence on our part led to deaths and kind of demonstrates some of the challenges that our communities that we serve have experienced as receiving healthcare in the prison system. Correctional environments themselves can exacerbate health conditions or create health conditions. This is a picture from quite some time ago now. This was when we were overcrowded in our state prisons and we were converting our prison gyms into housing units. But you can imagine when you have people kind of packed in like this, if you have something like a tuberculosis outbreak, it will impact many people. People who have severe mental illness, if they were in this environment, it could exacerbate their health conditions. The kind of epidemic of hepatitis C that we see among people who are incarcerated comes from the structure of the prison itself, because we know people are tattooing and sharing needles, but yet don't have access to things in the community that we use for harm reduction, like being able to access clean needles or to clean their needles with bleach. And so as a result, almost 40% of our state inmates in the California prison system have hepatitis C as compared to less than 2% in the general population. And that the access itself inside the prison may be limited by institutional policies. This is a picture of patients with HIV at San Quentin State Prison that at one time when they were waiting to see a provider, they would just line up all the HIV positive patients in a row to see the one HIV provider who came into the prison every week. So if anyone knew that that was HIV clinic, obviously you would know who's HIV positive. And in the prison system, that can be a real liability around safety for patients. And so you can imagine some people may not want to share that information and may then not get access to services that are available because of these reasons. And it's important to realize, the prison or jail system is a punitive environment. The focus is on safety and security. Healthcare and healing really is secondary. And I think this picture kind of sums that all up for me. You can see there's an individual in a holding cell getting their blood pressure taken, and the fact that they need to be, secure from a prison perspective really trumps any of the healthcare, because we all know that this is not going to give us an accurate blood pressure. And so really kind of in that system, it's really difficult to prioritize people's health. Things that we focus on in the primary care setting, like self-management of chronic conditions, is difficult or nearly impossible. You could imagine somebody who has diabetes is not going to have access to a glucometer, to their own needles. They're not going to be able to check their own sugars or adjust the amount of insulin that they get themselves. It's all going to be done for them because of the concerns around safety and security. And so people who have spent a long period of time in jail or prison oftentimes have sort of a learned dependence on the healthcare system inside and may not possess those self-advocacy or self-management skills that we all know are really important to managing people's chronic conditions. So an important piece to realize when caring for these patients that this is an additional barrier that people face. But that while many people are incarcerated in this country, 95% will return back to the community. And I think this is a really important piece that I always like to kind of pause for a second to reflect on, because if 95% of people in the correctional system are coming home, that means they're really part of our communities. And so when we think about our communities, when people go to the system of incarceration, it's temporary, they will be coming back. And I think it's important for us to think about what is happening inside to our community members, and how do we then think about connecting them back to healthcare services when they come home. And this is a picture of a patient who was at San Quentin. He was an elderly gentleman who had severe COPD. I think, again, this is another photo that sort of illustrates this tension between the punitive environment of the correctional system and the healthcare system. His oxygen tank is outside his cell because of concerns that it may be a safety risk, even though he's quite frail. And that tube that's going through that port there in the door was getting kinked several times a day, so the patient wasn't getting enough oxygen. But really, what I wanted to talk to you about with this person was really more about what happened when he left prison. He was released from San Quentin to Salinas with a very small oxygen tank that was not full. By the time he rode the bus back down to his home county, he had run out of oxygen and had really no other recourse except to go to the emergency department. So at some point, he ended up violating his parole, coming back to prison. I met him again, and I thought, well, we really can do better here. Let's connect him with services in the community. Let's get him oxygen, enough to get him back, to bridge him and set up oxygen for him in the community. And when I asked him, if he would be willing to sign a release of information so I could connect with his primary care provider, he actually did not want to sign that release because he was concerned that if the primary care provider knew that he was in prison, they may not let him come to the clinic. And because Salinas is a more rural area, there's less opportunity for care. He didn't want to inadvertently jeopardize his care because he had been in a different clinic, and he had felt, when they had heard that he had a history of incarceration, that he was treated differently, and he didn't feel comfortable going to that clinic anymore. So it really kind of illustrated to me that there was a lot that we could do on the health system side to improve care for people coming home from incarceration. So what do we know about people when they're released from the prison or jail system? They oftentimes don't have any medical discharge planning. And if they get any medications, it's often a short supply. It can be a week's worth of meds. It could be 30 days from the state prison system. But that means as soon as they leave, the clock starts ticking, and people really have this pressure to get into care. That many people may leave the system without health insurance. This has improved since the ACA, and that many of these individuals are eligible for Medicaid in our state prison, and many of our jails are working to try to enroll folks prior to release. But not everybody leaves with insurance, and that if you have insurance going into the system, if you're in the system for any length of time, you may have a lapse and have to renew your insurance. So there's some challenges there. Another really important piece to think about is that individuals experience what we call the collateral consequences of incarceration. So when people leave prison or jail, kind of all their social determinants of health are oftentimes up in the air. They may not have a job, a place to live, they have to reconnect with family, they may want some additional training or education. But yet, in order to do that, which is really challenging to begin with, these individuals may face additional barriers to their social determinants of health. And so collateral consequences are when people have done time in the prison or jail system. If they have a felony conviction, they may face these additional barriers. So examples of that are food stamps. There's a national food stamp ban that in some states, people with felony drug convictions are not eligible to get food stamps. I'm happy to say in California, we've overturned that, and that's no longer an issue in our state. Other examples are Section 8 housing. People with felony drug convictions may not be able to access Section 8 housing. If they want to go home to their families in Section 8 housing, they may be putting their family members at risk. So there's actually over 30,000 documented laws and policies in our country that are collateral consequences of incarceration that continue to punish individuals even beyond the time that they've done in their prison or jail sentence. And it makes it even more difficult for people to meet their basic social needs. What about their health when they come out? Well, we know that people's health actually deteriorates when they come out to the community, that their chronic medical conditions, HIV and substance use disorders, get worse, that they're more likely to be hospitalized, and that they have a higher rate of death. And this is a seminal study from the New England Journal of Medicine in 2007 that looked at over 30,000 individuals paroling from the Washington state prison system, that found that just by the fact that people were being released from prison, they were 12 times more likely to die in those first 2 weeks post-release. And the reasons are drug overdose, cardiovascular disease, homicide, suicide, and cancer. So many of these are medical issues that we all as healthcare providers see as our responsibilities and feel like we could intervene to help individuals during this time. So, it's very easy to kind of point the finger and talk about the correctional system, right? We talk about it's a punitive model, it's not healthcare, they don't know how to do continuity of care, they don't set people up for success. But what I think we often don't talk about are what are some of the other barriers that patients face in engaging with healthcare systems in the community. And a lot of our work in the Transitions Clinic Network is really focused on that piece. And I'm going to talk more about the work that you're doing, and I think you'll get a better sense of what I'm talking about. But I think it's important to recognize that patients that we serve, these are oftentimes poor patients coming from communities of color who have already experienced discrimination at the hands of the criminal justice system, as well as at the hands of the community-based health system. So, we know we're under federal receivership. We know people were dying from preventable causes. They maybe had negative experiences inside. But what we also find is that people actually do experience discrimination at the hands of our health system. There's a lot of data that already shows that people of color with low socioeconomic status, lower levels of education, experience discrimination in healthcare settings that results in worsening of their healthcare outcomes. And what we have found in studies is that also people have experienced discrimination solely based on the fact that they have a criminal justice history. So in one study, 42% of recently released prisoners had experienced discrimination based on their criminal justice history in the healthcare setting. So I think it's important when we start thinking about what we can do on our end for receiving our own community members who are coming back from incarceration, that this is a really key piece to think about when we design our services. So in order to improve health outcomes for individuals, I think it's really important that we shift the paradigm of healthcare. As I mentioned, there's a punitive model in prison. It's pretty easy for us to, have a caring, healing environment. I think that's all our values and goals within our organizations, but we want to shift away from that. But then in the bottom pictures, you'll see we want to also change the model of primary care, not just to solely be focused on the person's physical health, but to really broaden our definition of health and well-being to include behavioral health conditions, the social determinants of health. And so you can see in the picture below, there's, my colleague Levis Owens is seeing a patient in the primary care setting, but kind of thinking about how do we adapt our primary care settings to be more whole person centered and more holistic. And the next picture is actually of our community health workers going out to visit a patient and addressing issues of food security with that individual. So one example of the social determinants of health. So to kind of think about this program, I'm going to tell you a little bit more about how we designed it so you can get a better sense of what the components are. We started the Transitions Clinic program at Southeast Health Center in 2006. This is a picture of Ron Sanders on the right, one of the community health workers with one of our patients in clinic. And we engaged many community stakeholders and formed a community advisory board, which was very instrumental in this work, that include individuals who are impacted by the criminal justice system, patients, family members, the San Francisco Department of Public Health, City College of San Francisco, Legal Services for Prisoners with Children, to really kind of put our heads together to think about what would an ideal model look like. And what we found was that there are some key pieces that the community felt was really important in developing these models, and that it was most important that when we design programs, when we implement them, and when we evaluate them, that people who are impacted by these systems are included in those processes. Key strategies for success, as I mentioned, a broad definition of health and well-being, so not just focusing on the person's physical health conditions, adapting the systems to be more patient-centered, looking to empower and educate patients, helping them, going from this model of maybe more dependence on the healthcare system to more self-advocacy and self-management, that it was important to favor reintegration. So we don't want to create health systems that are separate for people coming back to our communities. These are community members, so they should be served in the clinics that are part of our communities. They should be seen alongside their partners, their children, their grandparents. And that we really need to make sure we're not inadvertently replicating the correctional system. People are coming from a system where they felt like it was punitive, they couldn't necessarily share, there was no confidentiality or autonomy, and they were looking for some really basic things, which is I want to have a relationship with my provider and know that that provider is going to maintain my confidentiality and be supporting me and is not reporting or beholden back to the criminal justice system. So as a result, the model of care that we developed is implemented in existing primary care clinics. We're not looking to create some separate system. We're just looking to enhance and build off of what we already do. So the program or the transition clinic model is made up of these 4 things. 1, culturally competent primary care teams, so providers that understand the needs of their patients. Community health workers who have past histories of incarceration that are integrated within the primary care team. I'm going to talk at length about what the community health worker does. That our patients are centered, our services, are patient-centered, and that we want patients to have this kind of broader kind of health and well-being addressed with behavioral health integration, medication-assisted treatment for substance use disorders, reentry support around the social determinants of health, and also thinking about ways we may be doing things inadvertently to be challenging for our patients. So I'll give you just a quick example. I think the 15-minute late rule is particularly challenging for the patients we serve. You can imagine someone coming out of incarceration, maybe they've been incarcerated for a number of years, they're not familiar with the community, they may have some post-traumatic stress disorder symptoms as a result of their incarceration, and so just navigating the bus to get to the clinic on time may be really difficult. And so if somebody makes a major effort to come, already feels mistrustful of the system and then shows up and they're more than 15 minutes late and we just, across the board say we can't see you, that's really going to alienate our patients. And so in our clinics where we practice, we try to find ways to, if someone's late, to still make sure we address some need. We may not be able to have a full visit, but we never turn people away. And I think that's just an example of one thing that we've done in our program to try to meet the needs of our clients. We then, of course, try to help them navigate transportation better and understand how to get places. And hopefully over time, they're no longer going to be late. But I think it's understanding what some of the needs are and how some of our existing systems may not be supported. And then lastly, partnerships with existing community organizations that serve formerly incarcerated individuals. So really kind of breaking down those walls of the primary care system. Most primary care clinics are pretty static. We just wait for people to come to us. We may have some partnerships with community organizations, but we certainly don't have a lot of staff that are kind of going back and forth. And so trying to have more relationships, staff like the community health workers are both in the clinic and in the community, and really strengthening those partnerships to address the social determinants of health. And then also building more relationships with the criminal justice system to have a seamless transition of care from the system of incarceration to the community, and also building relationships with community supervision so that we could advocate for and support our patients who are on probation and parole. So what do the community health workers do? So outreach. Patients, as I told you, are maybe mistrustful of the system. They may have competing priorities around their social determinants of health. So the community health workers go out and look for people who are recently incarcerated. And this is a picture of our community health worker visiting a patient in the hospital. So we get referrals from the emergency department and hospital that people may be using acute care settings for their care. So we work hard to bring them into the primary care setting. This is a picture of a health fair at one of our state prisons. This is another way we meet people prior to release to build those relationships for improved continuity to get people in. This is a picture of our Santa Clara program. have an outreach van, and they go out into the community to homeless encampments, and that's one way they outreach to get patients into the program. So it's really meeting people where they're at. And then this is a picture of one of our programs that we have worked with in the past in Alameda County, where they actually pick patients up at the gate at San Quentin State Prison. Health system navigation. This is our community health worker, Ron Sanders, with patients in our waiting room. Believe it or not, we've had patients show up to clinic. They don't know to register. They sit in the waiting room for 4 hours, and when it's time to close the front doors, the custodian is asking, you know, who's this person still sitting here? So even within our own building, patients have gotten lost. So this is Ron in the waiting room. He spends a lot of time out there making sure people feel welcome, helping them navigate the process within our own clinic, and also within our larger health system, which you all know can be quite complicated. This is a picture of a visit. We actually have the community health workers at times join us for the primary care visit with the patients. They can act as cultural interpreters and make sure that they help patients best communicate their needs and understand what the provider is saying. This is another picture of a patient with one of our behavioral health staff. There's a lot of, I would say, I think a lot of misconception around mental health services, or a lot of stigma around mental health services, and having the community health workers vouch for the mental health provider is really helpful in getting patients to engage with these services. Here's a picture of one of our community health workers going over some medications with the patient. They do some basic health education and self-management support. This was a homeless patient who had stored all of his medications in a locker for about 6 months, and then came in with 2 roller boards of medications, and the community health worker is sort of helping him sort through it in this photo. We also have done some healthy cooking classes for our patients at the clinic, teaching them how to learn how to cook, utilize food pantry items to make healthy food in efforts for improved self-management of chronic conditions. Social service navigation, we talked a lot about the social determinants of health. Community health workers help patients navigate all of the resources in the community. This is one of our community health workers delivering food to a family, which both parents were impacted by the system of incarceration. And here is our staff shopping at the food bank to get food. We have a small food pantry in our clinic, and also, as you saw, we sometimes bring food to patients. And we have a food pharmacy as well, because we found that people coming out from incarceration have high rates of food insecurity, which impacts their acute care utilization. So one example of how we address the social determinants of health. Here's a group of people who had graduated from the community health worker program. The community health workers help people get into training programs. These are individuals who completed the community health worker training. But we also help with other educational, job opportunities, et cetera, around the social determinants of health. And then advocacy. This is a picture of Richard Medina, one of our community health workers who has been involved in a lot of advocacy, sort of thinking more broadly, what is the role of a healthcare provider system in addressing the policies of mass incarceration? And many of our community health workers are involved with our local reentry councils and can share stories of what the patients are experiencing to then influence policy, as an example of local advocacy. And then lastly, emotional support and mentorship. So the community health workers really support the patients. Patients may be, disconnected from their families because they're in and out of the system of incarceration, and they also mentor them. A lot of times they're very inspired by the community health workers because they see them as someone similar to them who has now succeeded. And this is a group of patients who went to visit a museum to address some of the kind of isolation that people may experience as coming out of incarceration. So our program, we've studied the program. We've found with a randomized control trial that patients in our program have 50% fewer visits in the first 12 months post-release as compared to other individuals in our safety net system here in San Francisco. In another propensity map study that we did with one of our programs in Connecticut, we found that TCM, people in the TCM program had fewer episodes of preventable hospitalization, so they had half as many. And when they were hospitalized, they had a shorter length of stay in the hospital. We also found that when our patients are referred directly by correctional partners, they had fewer acute care visits. as compared to those referred by community partners. So really an important plug for making those connections with the criminal justice system. And we also found that our program does reduce some criminal justice contact. The data does not show that our program is associated with fewer arrests or convictions, but that it is associated with fewer days incarcerated and fewer violations, probation and parole violations. So it's one way that as health systems we can impact the criminal justice system. Our programs are funded in many different ways. As you all may know, funding community health workers can be incredibly challenging. Most of our programs sort of rely on variable sources, kind of braided funding, where they use different sources for supporting the community health workers. Some examples, shared savings with managed care organizations, and Anne is going to talk more about her work in Vallejo, and she can talk about her partnership with Partnership Health to do this work. The whole person care waiver under the Medicaid 1115 waiver. Have Homes is an emerging opportunity that's a very good fit for this program. Some of the other things we've seen are partnering with the criminal justice system. For instance, AB 109 dollars for criminal justice reinvestment. Many of our sites have utilized this funding in partnering with their criminal justice partners, like our colleagues in Santa Clara County. And then also looking at other grants, and I'm going to kind of highlight that, as you know, you heard me say that people are more likely to die in the first 2 weeks post-release from drug overdose. So I think, as many of you know, there's a real focus on opiate use disorder and a lot of funding that has been coming out. So that's something worthwhile looking into and caring for this population. We do have a document that we put together that kind of goes into these strategies in more detail, and we'll make sure that we put that up on our website and send you all the links so that you can get more information. And we're more than happy to have an offline conversation with anyone about these funding strategies. That could actually be a whole presentation in and of itself. I'm sorry we don't have more time. So as I mentioned, we're in 29 programs in 12 states in Puerto Rico, and 8 programs in California in these particular counties. And so I just want to spend the last 5 minutes here just kind of quickly going over this opportunity, just to make sure that we're all on the same page and that you can have questions at the end. So the objective is, we want to build a network of clinics across the state to improve our capacity to care for people coming home from incarceration. We want to enhance primary care providers and systems knowledge and skills in caring for these individuals. We want to create employment opportunities in the healthcare field for people impacted by the criminal justice system. I think our data has borne out that people who have a shared lived experience really make a difference in the lives of their own community members. And this is a way that we can also support impacted people by the, people who are impacted by the criminal justice system. We want to work together to create more sustainable funding mechanisms for these programs. And we want to work together as a network to advocate for the needs of our patients. What will we learn during this opportunity? Really the goal is for each site to leverage their own resources within the clinic and develop the model. So I think, I hope that now you have a pretty good sense of what that looks like. So you're going to learn how to implement the model. And in the interest of time, I'm not going to go into all of these, but you can kind of see these are the domains that we plan on addressing. And this is all in our informational packet around the program. And so how will it be structured? It's a year-long program starting in January. Participants get structured and comprehensive technical assistance and coaching. We have kind of a structure of technical assistance, but then we work with sites individually to help figure out how do you implement this model within your system. And so we're hoping to work with up to 25 clinics. As far as the time commitment, there are 2 day-long in-person meetings over the course of the year. There's monthly 1-hour calls. There's quarterly site liaison calls, so it's about 2 hours every quarter. And then we're working with you all sort of individually. We do expect that sites are kind of looking to develop these models and sustain them and are willing to participate in evaluation and quality improvement exercises. So as I mentioned, this is an opportunity to implement programs at existing health centers. These are not separate clinics, even though the name may sort of sound like a transitions clinic. It's a transitions clinic program. So federally qualified health centers FQHC lookalikes, community health centers, and also behavioral health centers that have primary care programs would be a good fit for this program. Kind of one thing that's critical, as you've heard, is that all sites that we work with employ and embed community health workers with histories of incarceration into their primary care team. So that is one requirement of participating in this work. And that each site needs to have some demonstrated support from at least one high-level administrator and clinician on their team, and that we're going to prioritize sites that are located in neighborhoods that are disproportionately impacted by incarceration, that maybe already have or are moving towards integrated behavioral health services that offer medication-assisted treatment and have demonstrated a commitment to working with community health workers. So again, I mentioned, we really hope that sites are interested in implementing this and sustaining this for the long term. Sites will have to, if you don't have behavioral health and substance use integration, start working towards that aim. Be willing to collaborate with the criminal justice partners. As I mentioned, hire an integrated community health worker, and be willing to incorporate addressing the social determinants of health as part of the work done in the clinic. We found what works well is that each team has to have a clinical champion who's going to be the person on the ground, have seen these patients or working with the patients directly, somebody who is a dedicated community health worker supervisor. People who are very good for that role tend to be mental health providers like a social worker or a therapist. Those are some examples, but that doesn't have to be, but it's somebody who can dedicate time to being the supervisor for the community health worker. And then of course the team will include the community health worker that you all will hire. And then we encourage sites to, obviously you're going to need support from the overarching clinic administration in the way of, being willing to implement this work, but to have them as key stakeholders and working on this is incredibly helpful. That other human resources staff are involved as far as hiring people with histories of incarceration. Thinking about, are there correctional partners you would want to include, or other social service or community-based organizations. So how much will this cost? I'm sure that's been on everyone's mind. We are just so grateful and appreciative of the support of both California Healthcare Foundation and LA Care was making this possible. They're going to be funding our time doing the technical assistance and training and all the convenings and travel associated with it. What we expect from sites are that they're going to offer a clinician, who are going to be seeing these patients, as well as a community health worker supervisor, and have their own funding mechanism to support the employment of a community health worker. So again, we're trying to build off of what sites are doing already, right? So you have clinicians in your system, you have potentially someone to be a supervisor. The additional funds are generally paying for the community health worker, but this is something that we feel is worth developing in the clinical environment, because as we move more towards value-based payments and thinking about these complex, vulnerable patients we serve, working with community health workers as part of the primary care system is really the direction we're all headed. So I think it's a good opportunity to kind of get a leg up on that type of work in the primary care setting. Each site will receive up to $28,000 across the project period for things like travel, to support focus groups or incentives for patients. Those are just some examples. And then for folks to apply, every clinic does need to submit an application. It's by Friday, November 16th, we need people to do a site assessment. And the assessments really give us a better sense of what are the resources you are leveraging in your clinic system. So that's how everyone starts the application process, by doing the site assessment. We'll review the site assessments by Tuesday, November 27th. And then each site that is selected will be invited to submit a full proposal, which will be a series of questions that we send you that we would ask for you to return by Friday, December 14th. Then we'll review those applications, notify people before the end of the month, and our first kickoff meeting is Tuesday, January 29th of 2019. So with that, I'm going to stop talking. I'm going to turn the mic over to Ann Finkelstein, who is my colleague at La Clinica, who has started the Transition Clinic program, and she's going to talk a little bit about her experience and we'll make sure we leave 10 minutes at the end for any questions and answers.
So thanks so much, Shira, for inviting me to participate in this call. I just want to share a little bit with you all about how I became involved in doing this work and a little bit about the story of how the Vallejo Transitions Clinic at La Clinica came into being, and a little bit about some of the challenges we faced and what really a lot of the rewarding aspects of doing this work have been in our experience. So before I ever went to medical school, I was working in a drug court. So I really went into medicine with the idea that I was going to work with prisoners, and I'm very interested in that population. And I learned about the Transitions Clinic Network while I was doing a rotation at San Quentin through UCSF as a medical student, and found it very inspiring. My first job after my residency was at Kaiser in Vallejo, and it quickly became very evident to me that Vallejo is very much a community that's deeply impacted by incarceration. Just so many of the patients I met either had personal experience of incarceration or had a family member who was currently or formerly incarcerated. So I brought that to some of the leadership at Kaiser and Vallejo about the idea of starting a transitions clinic there. Wasn't able to get it done at Kaiser, but subsequently when I started working for La Clinica, we're a community clinic, pretty much the only one in the community of Vallejo. And the administration there was very interested in this model and shared my belief that this was definitely a community that could benefit because of having so many people here who've been impacted by incarceration. And I think really the first challenge then was finding a funding source, particularly for hiring the community health worker. As Shira mentioned, you know, there's growing acceptance of these types of models of providing some type of case management or peer support for patients with complex needs, such as patients with a history of incarceration, but there aren't necessarily clear funding mechanisms in place for these programs. So you know, under mentorship from Shira and from the Transitions Clinic Network, I ended up engaging in a dialogue with Partnership Health Plan, which is our Medi-Cal HMO here in Solano County. And it took a while and a lot of conversations and a lot of thinking about how the funding would work. But eventually, inspired by our idea for the program, they put out a call for proposals for a social determinants of health grant program. And we were awarded a grant and were able to start our program in 2016. Some of the other ongoing challenges that we have here in Solano County, just a general lack of resources in things that we think of as social determinants of health, particularly housing. We've been very much impacted by skyrocketing rents that have happened in San Francisco and Oakland. That trend is really continuing to expand outward. We're a little bit north of the Bay Area, but rents here have been increasing dramatically. We're a community that has only one shelter, and that really doesn't have a lot of halfway houses or transitional housing. So that's an ongoing challenge with our patient population here. We also see a lot of challenges in terms of providing behavioral health services. We don't have a lot of providers in the community providing medication-assisted treatment with Suboxone for folks with opiate use disorders. So that's something we've started doing here. And then linking patients to mental health providers in the community, particularly when they're on parole, has been a big challenge as well. But really, I'm so happy to be doing this work. I think as a medical professional, you know, many of us are really looking to be able to provide people with the tools to feel empowered to take control of their health. And that's very challenging when you're working with patients who are living in poverty and face a lot of barriers to getting their needs met. But really working with a community health worker has just been so rewarding. It gives us the ability that I wish I had with all of my patients to really work on addressing social determinants of health. It makes it much more possible to gain the trust of patients coming in, because the community health worker we work with here, her name is Madonna Garcia-Crowley, that's her picture on the left. She has lived experience of incarceration, of drug use. She's also a cancer survivor. So, you know, when patients speak with her, she's really able to quickly gain their trust. And she's really just been instrumental in helping us develop the program in a way that we're going to really serve this population and stay accountable to the needs of our patients. I think another thing that's been incredibly rewarding about doing this work is that it really feels like we're constantly in need of creativity to come up with how we're going to serve our patients. We run into gaps in services, you know, and then I've had to really grow as a clinician to be able to fill those gaps. I mentioned learning how to do medication-assisted treatment with Suboxone. We now do hepatitis C treatment on site. You know, and then seeing gaps in terms of social determinants of health. Madonna in that picture is standing in front of our food pantry because we identified very early on that a lot of the folks we were seeing in the transitions clinic had a lot of unmet needs around food security. Working in the transitions clinic has really allowed me to build more connections within our community here in Vallejo, and sort of get outside of the little box of our community clinic and forge relationships with community partners, which I really value. And also another thing that's just wonderful is just being part of the transitions clinic network. I think we've been the beneficiaries of support and mentorship really from the beginning, from, you know, when I was first trying to think about how to implement this model in Vallejo. Shira Shavit and Anna Steiner have been there to help me figure that out, help me with my grant application. And then Madonna has been able to benefit from mentorship from the community health workers in the San Francisco program, and was able to participate in an online training program to really learn how to do the work that she's doing well. And we, you know, being part of the network, we're in touch with clinicians and community health workers across California and across the country. So when we encounter a challenge, there's just that wealth of experience that we can draw on for ideas for how we can meet the needs of our community here. And we're able to step back and take a look at some of the issues we see on a day-to-day basis here from a systems perspective, and look for ways that the Transitions Clinic Network as a whole can advocate for policies that can really change the lives of our patients. So I'm happy to take any questions that you all might have about our work specifically here. Thank you.
Thank you so much, Anne. I really appreciate that, and appreciate you taking the time to answer any questions. So folks could go ahead, if you have specific questions, go ahead and type them in. I do see one question in the Q&A box, which I will read. Danielle Carter asked, at what point in the year do you expect sites to start seeing patients? Is the purpose to develop TCN at sites that don't currently have a TCN, or to help support sites already seeing these patients, perhaps in a different model, and providing structure for the program, or both? In the former, clinics may not start seeing patients until towards the end of the year. So, you know, really our goal, I mean, we did develop a model of care. As you can see, it's quite in broad strokes. We also, with the support of the California Healthcare Foundation, we're really able to do some implementation science evaluations of our work to get a better sense of what are both barriers to doing this work and kind of facilitators, and to understand what are the core components of the model that are critical to doing the work. So, you know, we are hoping to, the purpose is to develop the TCN program. It really is a program of some of these core components that we know leads to improved health outcomes and reduced parole and probation violations. So that is the goal of this program. If there are sites that are already seeing individuals impacted by the criminal justice system, please reach out to us. We're happy to have a conversation with you. We can talk about how, what pieces might be able to be implemented, you know, in further developing the program. So without knowing any specifics, what I would imagine is maybe there's clinics that are seeing individuals impacted by the criminal justice system, but maybe don't have community health workers as part of their model. Those would be perfect sites that we would love to work with. You know, if there's other models or some divergent piece and you're unsure if it makes sense to implement the program at your site, just please reach out to us. We're more than happy to have conversations. You know, we will provide a recording of the webinar and slides will be available. You know, unfortunately, we only have so much time for this webinar. So there's a lot more that could be said and maybe more nuance related to your site. So we're more than happy to have conversations. So please just reach out. What are the requirements of the full proposal? That's a great question. It's just a series of questions that we're going to ask, no more than 10 short, I even wouldn't say essay questions, just questions that we ask people to respond to. And that sites will be required to provide 2 letters of support, one from a clinical administrator saying that they fully support the implementation of this model and that they would support hiring community health workers with histories of incarceration, and then 2, just a letter of support from a colleague that can speak to your organization's ability to implement innovative programs. Any other questions? Yeah, how quickly will the site need to hire a community health worker? It takes time to pull funding together. I absolutely agree. So, you know, we're hoping that sites will have pulled the funding together, you know, before the start of the program in January, because then it does take time to also find a candidate. So I think that would be a requirement that funding is pulled together, because I think, you know, if it isn't, we don't know how long it'll take, and then you may be really out of sync with the other clinics that are participating. And I think what makes this work really kind of fun and also effective is that we learn together. So if one site is just so far behind, I don't think you'll be getting as much out of the training. Is there a minimum number of formerly incarcerated patients that a clinic must have a year? And the answer to that is no. And I love that question, because that actually signifies that your clinic knows how many people you have that are formerly incarcerated in your clinic. And that right there is an incredible step in the right direction. I just came from a primary care association meeting of Western states, and very few clinics are even asking that question. So that's kind of the first start. So the answer to that is no. Probably one question that may come up in your minds is kind of how many patients does a community health worker serve? They generally have a patient panel of 20 to 30 active clients at one time and may work with up to 100 patients in 1 year. So that might help thinking about kind of staffing. It doesn't have to be one community health worker. If you have funding to staff more, that's even better. But there's no minimum number of patients. It would be helpful if there's a way you can indicate how you know that, or how many patients you think you're serving. Other questions? Okay, oops, sorry, that just jumped on me. For sites where it has been implemented, are the sites made exclusive for TCN care? If not, did it affect the other population generally coming back to those sites? For example, female or pediatric population. I really appreciate that question. I think that's often on people's minds. So just to kind of reiterate, the idea is that we're working in existing health centers. So these are clinics that are already caring for all different people in the community. So the sites are not made exclusive for TCN care. In fact, that's what we are hoping to avoid. We are looking instead to integrate the care into regular primary care. And no, it does not affect other populations. And as I mentioned, these are our community members. So when we're talking about communities impacted by the criminal justice system, we're probably already caring for their children, their partners. And so no, it really has not impacted that. We just kind of integrate everyone into the clinic. They come sit in the waiting room just like everybody else. Next question, are there current TCN partners who support subcontracts with clinics that conduct harm reduction services? So that's a great question. Yeah, many of our sites do partner with harm reduction organizations to address this. And Anne, do you want to talk a little bit about the work that you've been doing?
Sure, yeah. So, I mean, we just became part of the Hub and Spokes network that's doing treatment with buprenorphine for people with opiate use disorder in our community. So that's for both transitions clinic patients and any other patients with opiate use at our site. And we're also going to start doing on-site Narcan distribution. Hopefully, eventually, currently Solano County doesn't have a syringe exchange program, but that's something that's on our horizon as well, just because it's such a need in the community. And I know that there's several other sites within the Transitions Clinic network that have found ways to incorporate this into those issues into the services they provide.
Thanks, Anne. So the next question, can you explain a little bit more about the two separate funds available? I'm not sure if I totally understand this question. Julia, can you write a little bit more? Maybe while if anyone else has specific questions they want to ask. Maybe just to clarify, okay, annual 28,000, but a one-time 100,000. I'm not sure where you're seeing the one-time 100,000. Just so you know, in part, I'll just clarify. So for sites that participate, there are $28,000 in funds for travel to meetings. As we mentioned, there's 2 in-person meetings for support of things like incentives for patients' participation. We have found that it's oftentimes really helpful for sites to do focus groups with their communities. I'll give you one example of this, which was incredibly helpful when we first started the program in San Francisco. Our local county jail was really on board with the idea, very supportive, and said, you know what, we even have space across the street from the jail that if you want to put your clinic, you can put it there. And this was before we had decided to place the program at Southeast Health Center. We were kind of figuring out what makes sense, what are we going to do? And you know, we were thinking we would have it at Southeast, but when we heard that, we thought, wow, that's actually so convenient. You know, people come out of jail, they just come across the street. You know, they're only getting 2 weeks supply of their medication. So wouldn't it be great if they could just come across, get a refill of their medications, connect with the providers? And then when we did focus groups with the community and talked to our community advisory board, everyone said that's actually the worst idea we've ever heard. Nobody's going to come out of the jail, go across the street to get their medications. People want to go back to their families. They want to get out of that neighborhood as far away from the jail as possible. And I think, to me, that was a really good learning lesson of how, while something may sound really logical and great from a provider perspective, from a community perspective, it really may not meet the needs of the community. And so we really encourage sites in having community advisory boards doing focus groups with patients. And that's also where the community health worker comes in. It's really helpful to you know, have someone on your team on a daily basis when you're working with clients that could kind of help redirect you if you're sort of doing that same thing where you're well-intentioned but not really hitting the needs of your patients. Maybe you don't totally understand. I've been doing this work for 10 years and I still come across those types of situations at least once a week. And then also in building the program, the community health worker is really important in helping to come up with, when we're doing quality improvement or figuring out how to structure our program, really hearing from those community health workers. Okay, and so as far as the one-time $100,000 Danielle posted, that might be in relationship to Partnership Health. So, you know, Danielle said feel free to reach out to her specifically. Danielle, I don't know if there's any other information you want to share related to that, but just to be really clear, this particular funding opportunity is, you know, $28,000 per site. So if folks are work with Partnership and you're interested, please reach out to Danielle Carter.
And all right, we have Piper.
Oh, yeah, go ahead.
Closing that we are publishing a paper about that's going through how community health centers can pay for this model, and that should be out in the next month or so. That looks at different braided models that that Shira mentioned. There will also be in the new year, probably in the spring, funding opportunities for clinics related to expansion for medications for assisted treatment, because we would expect that all of these clinics have at minimum, an ability to prescribe medications for addiction treatment as part of the treatment plan, and there will be some funding available from the state. And if you have particular questions around that, you can ask me, or just make sure to sign up for our CHCF newsletter, where any funding opportunity we blast out to everybody. So that's just going to chcf.org and signing up for our newsletter. Well, we'll be closing, but again, you'll get an email from us with all this information. And thank you so much for joining us this afternoon.
Thank you, Kelly. Thank you, everyone, for joining. Looking forward to hearing from people. Please don't hesitate to reach out to us.